Welcome to the 40th session of the Transnational Vascular Interventional Radiology Journal Club. We're an open access virtual initiative to educate trainees on clinical research studies pertinent to VIR through monthly journal club sessions. Each TNVIRJC session focuses on a randomized clinical trial or meta-analyses, so level 1 evidence, accompanied by an overview of the relevant disease and intervention. Today we're going to be having Gavin and Thanmayi Parasu present on the DISCOUNT, DISTAL, and ESCAPE-MeVO trials. All right.
Hello, everyone. I'll go ahead and just get it started then. Today, we'll be discussing essentially the modern management of acute ischemic stroke caused by large and medium vessel occlusions, or LVO and MEVOs. This is a topic that has been seen as one of the most dramatic and also impactful shifts in clinical practice over the last decade, essentially fundamentally changing the prognosis for our most severely affected stroke patients. And we'll trace the journey from historical medical management to the current gold standard of endovascular therapy. So I want to start off by introducing ourselves. My name's Gavin, and thank you, Millie, for introducing us. But my name's Gavin. I'm a second year right now at UCSF School of Medicine. I'm very excited to start clerkships in about a month. So, this is going to be my last like hurrah before going into clerkships and, forgetting everything I learned. So I'm happy to be here. Thank you for being here as well. And Maya?
Hi, y'all. My name is Maya, or Thanmayi Parasu. I'm a second year at UTMB. Still got a way to clerkship, which I'm grateful for.
Hi, everybody. I'm Daryl Goldman. I'm an attending at Mount Sinai in neurointerventional surgery. My background is in interventional radiology. I did the integrated residency and then went on to do a fellowship in neuroendovascular. And now I'm part of a neurosurgery department, so mostly doing neurointerventional. However, I definitely still love to do body IR as well. So hopefully we'll do both at some point. It's nice to be here. I'm very grateful for the invite.
So we can go ahead and start talking about just a little bit about ischemic strokes and what we're trying to touch on here. So what exactly are we talking about? An LVO isn't just any stroke. It's really a blockage of one of the brain's main arterial trunks, like the carotid, the basilar, or the M1 segment of the MCA. If you haven't learned about those yet, you will. MEVOs are slightly more distal compared to LVOs. While they represent less than half of all ischemic strokes, they are the primary driver of death and severe disability. The clot's origin is actually most often cardioembolic, with AFib being the chief culprit, but significant atherosclerosis is also a major cause. So, understanding etiology is really key for secondary prevention. Pathophysiologically, and next slide, please. The event creates two different zones. There is the dead, unsalvageable ischemic core and the dying but salvageable penumbra. Our entire treatment paradigm right now is based on rescuing this penumbral tissue. If this tissue is not reperfused in a timely manner, it will convert to an unsalvageable ischemic core. So the numbers you see on screen right now highlights this extreme time sensitivity where every minute counts. However, time is not the only factor. The brain's own backup system, its collateral circulation, is a critical variable as well. Patients with robust collaterals can actually maintain a viable penumbra for much longer, which actually explains why some patients can benefit from intervention even many hours after their initial stroke. So let's establish a common understanding before we move on. Go ahead and just, read out the slides and follow along with me. So thrombotic really refers to anything related to thrombosis, which is the formation of blood clot or a thrombus in a blood vessel that can block blood flow. Embolic refers to something that is related to an embolism, which is a sudden blockage in a blood vessel caused by an embolus, which in turn is a traveling mass like a blood clot, air bubble, or even a fat globule. Additionally, there is something called TOAST. Now, TOAST stands for Trial of Org 10172 and Acute Stroke Treatment. You don't need to know that. We won't test you on this, I promise. But it's just, if you just need to know that this is a standardized classification system for AIS. It has several subtypes, which you can see listed here, and feel free to read a little bit more about it in detail once these slides are shared with you. And the next slide will show a modified Rankin scale, which we will refer to later on in our presentation. It's a 7-point scale that essentially goes from 0 to 6, It's used to measure the degree of disability or dependence in people who have had a stroke or other neurological events. It really assesses the functional outcomes and is widely used in clinical trials to measure disability, with scores ranging from 0, which means no symptoms, to 6, which means death. So, um, yeah, we also have a little bit of information here about the specific arteries that we're touching on, but let's go to the next slide. Next slide. Sorry, go to escape. Yeah, there we go. So let's go ahead and talk about the endovascular treatment of stroke due to medium vessel occlusion trial, aka the ESCAPE-MeVO trial. All right, to set the stage, let's discuss why this trial is even necessary. We know that strokes caused by medium vessel occlusions or MEVOs can actually be quite devastating. The data from prior cohort studies shows that even with our current best medical management, about half of these patients fail to achieve an excellent outcome, and a third remain functionally dependent in 90 days post-management. This creates a clear treatment gap. For large vessel occlusions or LVOs, we know that endovascular therapy is a game changer. But for these smaller, more distal MEVOs, its role is still quite unclear. This leads to a clinical dilemma. We have some non-randomized data suggesting a benefit, but the procedure is inherently riskier in these smaller arteries. Therefore, we're left with a critical need for high-quality randomized data to truly understand the risk-benefit balance and to guide our treatment decisions. Next slide. The primary rationale for this study is really simple. We we lack high quality evidence, and the current approach to MEVOS is often based on extrapolation from LVO trials and non-randomized data, which is just really not ideal. So this specific trial is important for several reasons. It directly asks if the proven benefits of EVT can be safely extended to this population. It will provide a level 1 randomized evidence that we need to either support or challenge what is already a growing practice in many centers. And ultimately, the findings from this trial and others like it would almost certainly shape future national and international treatment guidelines. The study has a very clear primary aim, and it's to prove that adding rapid EVT to best medical management leads to better clinical outcomes. We'll look at how they define and measure better clinical outcomes in a moment. The secondary aims are also crucial. They want to rigorously evaluate the safety profile of the procedures, assess patient-centered outcomes like quality of life, and from a healthcare system perspective, evaluate the cost effectiveness of intervention. Looking at the methodology, this is a multi-center prospective randomized trial. It's open label, meaning that the treatment teams know the patient's allocation, which is necessary for a procedural trial. However, to mitigate bias, it uses a probe design, which stands for prospective, randomized, open label with blinded endpoint evaluation. They enrolled 530 patients who were randomized 1-to-1 to either EVT plus medical care or medical care alone. By medical care, I mean best medical management, SOPs. And the most critical part of the probe design is that the 90-day outcome assessment is performed by staff who are kept completely unaware of which treatment the patient received. The eligibility criteria were also quite pragmatic. Patients had to present within 12 hours and have a confirmed accessible MEVO imaging. A key feature is how they defined a disabling stroke. They included patients with an NIH stroke scale score greater than 5, but also those with a lower score of 3 to 5 if the deficit was deemed disabling by a local physician. It's really interesting because this actually reflects real-world decision-making where a low score can still represent a devastating deficit in isolated aphasia. The exclusion criteria were standard for a stroke trial, designed to remove patients unlikely to benefit or whose outcome would be confounded by other factors, such as a large established stroke or a very poor pre-stroke functional status. And also for clarification, a lower score indicates a larger established infarct and more severe damage. Next slide. The primary outcome was an ordinal shift analysis of 90-day modified Rankin scale, or the MRS. Instead of just looking at a single cutoff for a good outcome, this statistical method actually assessed whether the overall distribution of outcomes is shifted towards a better result in the treatment group. The secondary outcomes were comprehensive. They covered the traditional functional independence cutoffs, early neurological improvement, and key imaging markers like reperfusion success. Safety outcomes focused on hemorrhage and procedural complications as well as mortality in 90 days. During the design and hypothesis portion of the trial, the team anticipated an estimated 10% absolute increase in the UVT arm. In other words, they really expected clinically significant improvements in patients' outcomes for the EVT plus best medical management group. However, the actual results show that EVT within 12 hours did not lead to better outcomes at 90 days compared to the usual care. In fact, the lack of improvement paired with the worse safety profile and a higher mortality at 90 days was also seen in comparable trials and led to those trials halting early. So the key takeaway here is that there needs to be more granular studies in the future, which we will touch on a little bit later. And now I'm going to hand it off to Maya.
Hey y'all. So I have the QR code in the corner here if you want to scan and look at the article itself. This is about the DISCOUNT trial, which is the endovascular therapy plus best medical treatment, or BMT, versus BMT alone for medium vessel occlusion stroke. So the background purpose and the objectives. Simply put, the mechanical thrombectomy is associated with the best medical treatment, and it's established for large vessel strokes. But its benefit for distal intracranial artery occlusions is quite uncertain, just as Gavin touched on. Previous observational studies suggested potential benefit, but were simply put single center retrospective and low in quality. Distal occlusions, however, represent 10 to 20% of all AIS involving intracranial vessels, which demands more investigation. The primary objective is whether MT plus BMT improves functional outcomes compared with BMT alone. Again, BMT is the best medical treatment. And this was found by the rate of good clinical outcome at three months, defined by the MRS scale that we touched on before, less than or equal to 2, and evaluated by an independent assessor blinded to the intervention arm. The secondary objectives was to evaluate procedural success, assess excellent clinical outcomes at 3 months, monitor safety, including vessel perforation, embolus, migration, and symptomatic brain bleeding, along with evaluating mortality up to 3 months. The study design was similar to ESCAPE-MeVO, in which it was a multi-center, open-label, randomized control trial with 2 parallel groups. So the first one was best medical treatment alone. The second group was mechanical thrombectomy plus best medical treatment. Inclusion criteria, along with participants, were adults above 18 years of age with distal intracranial artery occlusion and a NIHSS score over 5. The inclusion criteria was symptom onset to expected groin puncture less than or equal to 6 hours, distal occlusion confirmed by CT angiography or MRI, and then written informed consent from a patient or trusted representative. The interventions include a stent retriever devices, which is the Trevo NXT ProView, CatchView Mini, Preset Lite, and the TriGuard 13. And then the BMT was tailored to stroke etiology. Overall, the results showed that MT did not significantly improve functional outcomes compared with the BMT alone. So as we can see, the MRS from 0 to 20 in 90 days was 60 with EVT versus 77% with BMT. The mortality, however, was elevated with BMT, but hemorrhage was higher and elevated with EVT involvement. And then higher symptomatic intracerebral hemorrhage in the EVT arm highlighted procedural risks in smaller and fragile vessels. So overall, the trial suggests that BMT remains standard care, with thrombectomy considered selectively and carefully chosen distal vessel occlusions. Now we're going to talk about the DISTAL trial, which is the evaluation of mechanical thrombectomy in acute ischemic stroke related to a distal arterial occlusion. So endovascular treatment, or MT, is proven effective for large vessel strokes, as we repeatedly have touched on, but its benefit in medium or distal vessel occlusion is quite unclear. So this trial aimed to evaluate whether adding thrombectomy is necessary. The primary objective, similar to our previous articles, is to assess whether thrombectomy plus BMT improves functional outcomes via the MRS scale at 90 days compared to BMT alone. And secondary objectives, similar, were monitor mortality and procedural safety and evaluate the risks of symptomatic brain bleeding. The study design is a multi-center RCT, and participants were 543 patients with isolated medium or distal vessel occlusions, and the vessels here are included. The intervention groups were first thrombectomy plus BMT, and second was BMT alone. And the treatment window was within 24 hours from our last known well. And overall, the demographics lied in the fact that median age was 77 years, females at 44%, and the median stroke severity score, which is our NIHSS, is about 6. And IV thrombolysis administered in 65.4% of the patients. Similar to our previous articles as well, in the total trial, MT did not improve functional outcomes or reduce mortality compared with BMT alone in patients with medium or distal vessel occlusions. And so we can see that the predominant occlusion locations were M2, then M3, then P2, and then P1. And so there was no significant difference in MRS at 90 days. And in fact, the mortality increased with MT and BMT together and combined, as opposed to BMT alone, along with symptomatic intracranial hemorrhage or SICH. Overall, we just wanted to do a summary because we have 3 robust articles. And so I'm going to go ahead and discuss those. So these trials were focused on medium and large vessel occlusions in comprehensive stroke centers, which was good for internal validity. And it builds on existing literature and was exploratory in nature. Inclusion limited to disabling deficits, or NIHSS, was over 3 for these trials. Potential biases to consider is a selection bias. For example, the inclusion criteria in DISTAL and ESCAPE-MeVO trials allowed enrolling patients with lower NIHSS scores if they had a clearly disabling deficits, like Gavin touched on, which likely introduced selection bias that varies from physician to physician. There was also potential reluctance to randomize patients who may benefit from EBT, which may have led to dilution of the true treatment effects. These trials also predominantly enrolled patients with occlusions in the M2, M3 segment of the MCA, leaving the ACA and the PCA occlusions underrepresented as a whole. There was also center bias. For example, high volume EBT sites participated. And so these outcomes may not exactly translate to smaller hospitals. And there was also limited rural or community generalizability. Observer bias included the open label nature of the intervention, which creates potential for performance bias, where subtle differences in post-randomization care could significantly influence outcomes, despite protocol efforts to standardize care. There's also design bias. For example, technique heterogeneity. Operators could choose devices, aspiration, stent retriever, which could then introduce variability in performance. Along with this, the fact that BMT treatment can vary from physician to physician could also impact care as well. And so for results and future directions, just as a summary, across trials, adding EBT to BMT failed to show improved outcomes at 90 days compared to BMT alone. All 3 trials demonstrated consistent trend of increased rates of symptomatic intracranial hemorrhage with EBT, creating an unfavorable risk-benefit profile when combined with the lack of efficacy. The mortality signal was inconsistent, but ESCAPE-MeVO found a statistically significant increase in 90-day mortality with EBT, which was linked to a higher rate of serious adverse events. A significant and critical finding from these trials is that the prognosis for MEVO stroke patients treated with BMT alone is worse than widely assumed. And also in the DISTAL trial, we just saw that approximately 45% of the patients in the control arm suffered moderate to severe impairment or died by 90 days. So for future directions, these trials are needed in severe MEVOs, posterior territories, and low volume community settings. We also need refined patient selection, which would integrate advanced perfusion imaging and clinical severity to identify responders. Also, alternative therapies should be investigated. And also there's an exploratory segment, which includes identifying promising subgroups, such as a secondary analysis of ESCAPE-MeVO showed that patients with poor collaterals appear to be harmed by EBT, whereas those with good collaterals may have derived benefit. So a more focused analysis could be necessary. And so we included just a summary comparing the trial protocols along with the results. The main thing to see here is, of course, we know that the different occlusion locations. Along with that, it's the devices allowed, in which Discount had multiple devices allowed, while Distal was any commercially available device. And then Solitaire for ESCAPE-MeVO was indicated as the first-line device. Along with that, the time from last known well varied amongst these three trials. And then here, we also included comparing the trial results, which we had discussed in our prior discussion. So we just wanted to open up to any questions and let Dr. Goldman talk about her expertise.
So this was a really great summary. Awesome job. I want to touch base on a little bit about the limitations of these trials, which, I had spoken to you guys about adding more detail into your slides, and you did a great job doing that. I think that that's really the most important thing when we look at these studies, or any study that we read. We need to know the limitations, right? Obviously, we want to know the outcomes, include everything about the trial, but we also want to know, what might have been a limitation and why these outcomes might have happened, right? And does this really apply to all the patients, or, is there reasons that these outcomes, occur, essentially? And so you guys did a great job summarizing some of the limitations of these trials. I think, most notably for, we know, right, that EVT, thrombectomy for LVO, right, large vessel occlusions, is probably one of the most effective treatments that we have in medicine, right? And we know that, right? We have tons of data now to show that, right? And so everybody was very excited about these trials for medium vessel occlusion and distal vessel occlusion, okay? And it was pretty disappointing with the outcomes, but interesting, because honestly, we don't know, right? We have a lot of data from the LVO trials that is not prospective, but has, some medium vessel occlusions patients that are in those trials and stuff that we can also look at data from that. And that did show, some potential benefit for MEVO. And that's why we did these prospective trials, because we thought, we have some data already to show that it's beneficial, and then we did these prospective trials and it showed that it's not. The thing that, I want to highlight, which you guys did a good job, but you talked about, that the studies included low NIHSS, and you guys highlighted that was like that was maybe an issue, that they were allowed to include low NIHSS. Sometimes with a distal occlusion and less territory affected, the NIHSS is often lower, right, than an LVO, right? But the issue with these trials was that the median NIHSS was very low, right? So for 41% of the distal participants, the baseline NIHSS was less than 5 or equal to 5. Right? And so that suggests that potentially there was not equipoise when we were randomizing patients, right? That the proceduralists firmly believe that an M2, a very symptomatic high NIHSS M2, for example, should go to thrombectomy. And so instead of randomizing them in this trial, or enrolling them in this trial, and potentially not, randomizing to the treatment arm, they were taking them outside of the trial, right? Which is not having equipoise. So that's one of the biggest, critique of these trials, was that if most of the patients enrolled in these trials had such a low NIHSS, that were we taking patients for treatment outside of the trial and not having equipoise, right? You guys touched on that, the low NIHSS. The other thing is, we talk about MRS as a, outcome metric for most of these trials. MRS is, our basically our morbidity scale, and we look at 90-day MRS for most LVO trials. And these trials showed worse outcomes in MRS at 90 days. However, MRS is many feel is not a good outcome metric to actually use for MEVOs or distal vessel occlusion, because it's overall functional disability, right? And for some of these distal vessel occlusions or MEVOs, they have really specific neurologic, deficits that don't necessarily correlate with this disability scale, right? And so maybe that's not the best outcome measure for these patients. Okay, that's another critique, right? The other critique, as you said, was that most of these trials were stent retriever trials. Okay. And a lot of people feel that using a stent retriever very distal in a small vessel and dragging it through and around a lot of brain is very dangerous, right? And you saw that there was increased symptomatic intracranial hemorrhage in these trials. So many people are looking forward to aspiration trials, more aspiration trials for distal vessel occlusion and MEVO. Okay, that's another critique. And then additionally, the patient selection also for these trials, so sort of like what I touched on with the low NIHSS, was also like very old patients were included in these trials. The median ages were a lot older than for LVO, right? For our LVO trials. And so many people again say, was there really equipoise when enrolling these patients in these trials, or are people really just taking these patients anyway, right? Additionally, these were very heterogeneous groups of patients, right? So ACA occlusions, A1, A2, A3, PCA, P1, P2, P3 occlusions, and, MCA occlusions are very different types of occlusions, right? And using an NIHSS scale and using MRS scales for these, again, with very specific and different neurologic deficits and territories involved, is also potentially an issue, right? Obviously, you want high numbers of patients in these trials to be enrolled, and so including more occlusion locations allows for more patients to be enrolled in a better, powered study. However, it also is a very heterogeneous group and not necessarily a good comparison. I hate to kind of give myself a plug, but there are two papers that our group wrote really summarizing the issues with these trials. One is a paper that which I can send later, but it's in the one is in stroke, and it's about M2 specific occlusion. So I'll talk about that now. So we talk about how should we treat M2s moving forward, okay? Because M2 occlusions, which is the MCA second segment of the MCA, not an M1, so not technically an LVO, but M2s are very different, right? There are codominant M2s, there are non-dominant M2s, and there are dominant M2s. And a dominant M2 is really functionally the same as an M1, right? So M2s were included in these trials, and really, again, leading to sort of not necessarily like, questions about equipoise when enrolling these patients, right? It really should be only non-dominant or codominant M2s that are enrolled. And some of those trials did specify that, okay? But not all of them. And so that kind of also makes the outcomes a bit murky. And we just want to make sure that, people know that while M2s are considered a MEVO, like almost everybody still believes that they should be taken for UVT, no matter what this data shows. Because it's a very heterogeneous group, and they shouldn't necessarily be clumped with an M3 and an A2 and, all of that, okay? I think, I could go on and on, but I think I touched on most of it. So let's let some people ask questions. Okay. Okay.
We have
I
a
think,
question in the chat. I could
yes.
read it out loud. So Michelle was asking, when having a pragmatic trial like these, where clinical decision-making may compromise equipoise but be in the best interest of the patient, how do we balance doing what is best for the patient versus what we may discover to be better or not through these trials?
So this is something I asked a lot, a great question, something I asked a lot as a trainee, especially during my fellowship. If you really believe in, you know, evidence-based medicine, right, which we all should, we should be enrolling patients in these trials, right? And we should have equipoise. And we do not know as a whole if we don't have prospective randomized data on MEVO and distal vessel occlusion, or we did it prior to these trials. And so we don't know, right? We don't have the evidence. So we should be enrolling patients in these trials and we should have equipoise, right? Now, that's not always easy, right? If you have a patient with, luckily in some of these trials specified with M2s, non-dominant and co-dominant, stuff like that. But some of the ones that don't, people are very don't want to enroll a patient with a very symptomatic dominant M2 occlusion that patient might not get treatment when we inside feel that we know that it's beneficial, right? But what we're trying to show, I mean, that's why these trials are the makeup of these trials and how they're constructed is so important, right? Because you want to try to limit bias and stuff like that. And we know that functionally, like a proximal dominant M2 is basically an M1, and those patients should not be, eligible for trials like this. We should be taking those patients. But in general, if we don't know, we don't have prospective data, we should be enrolling in trials if it's available.
Just to clarify, can you hear me? Can you hear me? Oh,
I can hear you, Michelle, but
okay. Just to clarify, that means like basically tightening your inclusion exclusion criteria to ensure like the safety of patients, because I'm sure that that's like a very difficult line to straddle when trying to push forward the frontiers of what we know and discover better ways to treat patients. It's like balancing between what's safe and what we don't yet know that could be really beneficial. So I think these trials maybe away from it saying, but at the same time maybe tightening inclusion exclusion use way to ensure like safety of your patients while
I think you're cutting out, or is it just me? Am I cutting out?
No, I think she's cutting out for me as well.
Okay. Sorry, I missed a little bit of that, unfortunately.
Dr. Goldman, to your knowledge, is there any investigation going on into aspiration devices? And how do you see them making including certain scales, and what inclusion criteria do you think might be best?
Yeah, so I think again to make a trial that's a little bit less heterogeneous, right? To in terms of the occlusion location, and worry about the numbers that we're enrolling a little bit, on the back end, I guess. Um, there are trials underway for aspiration. There haven't begun yet, but they're in the early phases. And I think that they're going to be like the one of them will be specific for M2s, which is great because we want to just, put that to rest and make sure people are still taking M2s for thrombectomy, hopefully, or specific M2s, not every M2, but, and then, I think, including low NIHSS is fine. Like not all these MEVOs and DVOs are going to be very symptomatic. Um, but maybe using different outcome measures, like instead of MRS, using more functional, like more specific scales that really highlight those territories specifically, and then neurologic, deficits that come with them.
Yeah, definitely. I think I saw a couple like NIHSS, MRS, like a lot of physician specific or treatment specific scores. So I wonder what specific numerical values can be used instead that might not vary as much.
Um, Specifically like an NIHSS would be one, which we had in some, but it wasn't like the primary outcome, right? So even if you look at that, it can still be, a problem if it's not your primary outcome. But even an NIHSS would be better, right? Um, yeah. Also, like there's ones like aphasia quality or life scale in patients, stuff like that, basically, for the specific, like looking at the scales for a specific deficit.
Dr. Goldman, so for this area where there was not super robust evidence prior to this, what was the standard of care beforehand, and how do you think that the evidence shown in these trials will affect standard of care moving forward for MEVO and distal occlusions?
I think, you know, the treatment of stroke patients is very multidisciplinary, right? It involves proceduralists like us. It involves neurologists who are probably the most important, gatekeepers and really the people that are bedside with these patients, directing their care. And so I think, unfortunately, I think a lot of people really have taken this data and said MEVOs and DVOs shouldn't be treated, you know? Um, I think, we wrote these papers, a lot of people have written papers and commented on the trials, and obviously, people are highlighting, what's wrong with the trials, but it's dangerous, I mean, it's dangerous because even if you can think critically about these trials and their outcomes, um, not everybody does, obviously. And yeah, and so people, it's a little bit more difficult sometimes to try to advocate for patients and get them to thrombectomy. Additionally, um, you know, I think, I mean, it's just very interesting. Like the other day, I searched like AI, like different AI things for like, should you take a patient with like a M2 occlusion, right? Or, and AI will be like, no, based on these trials, you shouldn't take them because that's what's published, right? And that's what it's pulling off of, right? So, um, yeah. So I think you have to kind of, some people do look at AI stuff when they're when they're like recommending stuff. So you have to kind of like, really try to critically think about trials when they're published because um it's not all the way, it shouldn't direct necessarily how we practice all the time.
Why do you think these three trials were published in such close proximity to one another?
I think because, you know, it's a hot topic right now, essentially, right? And was. And so these trials were done similarly. And then there's sort of a push to get the data out there first or at the same time and present at the meeting that, is coming up. And yeah.
I see. Thank you.
Mhm. Any other questions?
Yeah. So I was wondering, like, in your own practice, given the kind of given the state of things in your own practice, what are like the clinical or imaging features that make an M2 occlusion more likely to benefit from a thrombectomy, like when you're in doing your thing?
Yeah, so you can sort of tell if it's codominant on like a CTA. You can tell where it branches and bifurcates into, from the M1 and then into the M3s. And you can tell the size of an M2, like if it's huge. And then additionally, where the occlusion is it proximal in the M2, distal, stuff like that. And then some people, we've kind of moved away from CTP, a perfusion study. But I think perfusion studies can be useful in medium vessel and distal vessel occlusion somewhat. I mean, honestly, the only time I really use it now is really distal occlusions or, if we can't even see an occlusion on the CTA, it can be helpful to guide you. But yeah, but that can also show you like the territory affected essentially by that M2 occlusion. But yeah, I think we mostly go by size, like how proximal the occlusion is and stuff like that. Left side versus right side, obviously very important, right? And how symptomatic the patient is. Okay, so if it's a distal right M2 occlusion and the patient just has a little bit of left-sided weakness, we talk about, is it disabling or not? Are these symptoms disabling? And if they're disabling, then they should go for treatment.
Thank you.
Mm-hmm.
Hey, Dr. Goldman, thanks so much for answering all of our questions. I was a little curious, just because I'm not too well aware of how do trials like this account for maybe like cost differences in the type of wires or like, because as there's obviously wires that cost a lot of money and can maybe have better outcomes, but depending on the center that a patient might come to, maybe those certain wires are not things that that center carries or in general, how do you kind of account for these things and even operator technical skill and such in these like big trials?
I mean, usually these trials are available at bigger kind of academic centers, right? In terms of, so that kind of sort of accounts, I guess, for operator skill or whatever, but not necessarily. Additionally, in terms of pricing, like, costs and stuff, the trials specify on certain things that, certain devices, but not every device. So wires, no, right? Like they don't specify what wire you use or what microcatheter, right? It's just, but in general, all our wires, are pretty similar. Like I wouldn't say that would cause much of a difference, but I don't think that they do account for that. They really account for the devices that are specified in the trials, and that's really it.
Gotcha. So it sounds like there's some level of standardization, like you mentioned with the devices, but those kind of small differences, we don't, is it that we don't necessarily need to account for them, or it's just that it's not realistic to account for them?
I don't think that it's really necessary to account for them.
Okay, gotcha. Thank you.
I think, I guess a guide catheter makes a difference, like for sure. But people use what they're good at, what helps their outcomes, what they're comfortable with. And that's honestly the best, right? Is if you use something that you use often and you like, right? So I think specifying that people have to use every single device throughout the procedure is not realistic and potentially not a good idea in general for outcomes.
Thanks for that clarification.
Mm-hmm.
And then similarly on patient selection, I was just wondering if age is something that's considered, especially with these medium and distal occlusions. You were kind of mentioning, especially with the stent retrievals, kind of the insult that can be introduced. So if integrity or of the vasculature in these smaller areas is something that's considered or kind of correlates with clinical outcomes.
Yeah, I mean, we don't have data to prove it, right? We don't have like a randomized control trial of stent retrievers versus aspiration in like medium vessel or distal vessel occlusions, right? But many of us believe that aspiration is safer everywhere, and for LVOs as well, but also for specifically for distal and medium vessel occlusions when you're in a very small distal vessel versus dragging a stent retriever across that, vessel and potentially, pulling it or any of that. So when I'm selecting patients, like when I'm deciding on my devices personally that I choose, I think a lot about anatomy and patients for sure. Yeah. I think in these trials, they're industry funded trials often. So, a specific device is being used in the trial. And which also, obviously there would be a lot of bias if you could choose any device. So, you kind of have to use one thing, but in general, it's not always, necessarily the best thing. We don't know that,
So I know in distal, they specifically said that any commercially available device could be utilized. Do you think it's better to specify and employ one device or, leave it up to the physician or the interventional?
I don't think it, I think that's admirable. You can use any stent retriever, but I'm just saying that if you were to include, like what I meant before about using one device, I mean like a stent retriever overall, generally. Like you can't compare aspiration, if you studied, if you study aspiration and stent retrievers in one trial, that could be fine as long as you're looking at both groups separately, or something like that. You don't have to necessarily randomize them against each other, but yeah, I think it was great to include multiple devices. I mean, yeah. Again, you could do a subgroup analysis and look at each device separately as well.
Yeah.
This might be a silly question, but I was curious about the timeline that they chose for inclusion criteria. I know they did 6 hours and 12 hours versus standard thrombectomy, I understand, can possibly go up to 24. I was curious how that might be impacting any data.
Yeah, I mean, they're trying to get the reasons they are doing this is because, right, like we have our early LVO data for, LVO was first within like 4 hours or whatever, 6 hours, and then expanded to 12. Then now we're looking at thrombectomy, 24 hours and after. We're looking at large core thrombectomy, you know what I mean? But like to try to really just look at MEVO and DBO early on in the research kind of data stages, it's good to do similar to like what we did for LVO early on and when we didn't have a lot of data, right? So that's why they're doing those more early window strokes. So if these had been positive studies, or if they become, if we have more and they're positive, that's when it's time to expand to, longer windows, I would say, right? And maybe, larger core, stuff like that for MEVO and DBO as well.
Gotcha. Okay, thank you. That makes a lot of sense.
Mm-hmm.
I have a question. So we brought up subgroup analysis earlier, and I was wondering, we talked a lot about the heterogeneity of the selection criteria of these trials. What do you think there'd be any benefit from doing further subgroup analysis with the data that we have from these trials? Try and see if
Yeah, and I think it's being done, but I think that overall there was, a majority of a certain occlusion in the trials, and they don't have enough power for a certain other occlusions. You know what I mean?
Oh, that
So
makes sense.
yeah, there is subgroup analysis done, and it's helpful. But overall, the main picture is still the same that people get. That overall, if you're reading the outcomes for these trials, you think that there's no benefit to EBT for MEVO and DVO, right? Because that's what the conclusion is. If you get into the nitty-gritty, you learn more about the trials.
I guess that's why it's so important to have sessions like these where we really break down the trials, talk about them with some experts in the field. Does anyone else have any questions? Michelle is asking, is there any discussion on techniques that will reduce risk of emboli during clot retrieval?
You mean like showering clot more distally, or yeah, okay. Yeah, I mean, there's always research and on this going on with devices and stuff like that. And yeah, for sure. Techniques such as like aspirating with a stent retriever, doing dual aspiration and stent retriever, and stuff like that. And they're always looking at aspiration versus stent retrievers and which one causes decreases the amount of distal emboli. So yeah, I think overall we haven't really looked at differences specifically for MEVO and DVO for this. I personally think any of those methods will be beneficial. For DVO and MEVO, I think, yeah, I think that aspiration in general, I mean, yeah, I think we have to compare both. It's very hard to say. But aspiration with a stent retriever for sure decreases the breakup of the clot going distally.
Okay, if no one else has any questions, we'll go ahead and end the session here. Thank you so much, Dr. Goldman, for taking the time and energy to come and attend this session.
Great
Thank you so much.
Thank you, Gavin and Maya, for putting together this
really
awesome session.